Alright, so this is Nursing 210, Coping in Labor, and this is Pharmacologic and Non-Pharmacologic Approaches. So coping is really important for anywhere labor happens, even if it's in the back of an ambulance or at home, in a birthing center, or in an inpatient delivery unit. So our summit at the end of the birth and delivery is this way. To start out with, it's really important to know what normal coping looks like. In early labor, the mother might be excited, she might be energetic, mobile, talkative, she might have diarrhea. As labor progresses, she's going to get a little bit more tired, a little more focused, a little bit more turning inwards, and she might even be nauseous or less talkative, of course. In transition, she's feeling a little bit more out of control. She might be irritable or fearful. She might be making irrational requests like, I want to go home, I get the baby out. So non-pharmacological interventions. All right, so the first one is positioning and movement. So this is standing, rocking, walking, squatting, or leaning on hands and knees. As we know, on hands and knees, it helps move the baby into that occiput anterior approach. So one study, actually in the 50s and 60s, a researcher and his team started investigating the effects of maternal position and kind of set the stage for how the studies discovering that later went. In this case, he found that compared with recumbent positions, upright positions during labor caused more intense and frequent contractions and more rapid cervical dilation. So what they're finding is a woman on her back doesn't progress through labor as quickly, and it actually even might cause arrest of the fetal descent. So the benefits are women move around on their own anyway. They're still responding to their own body's needs and their own discomforts. So this reduces pain, and it also helps the baby maneuver into position. The only problem might be is if she's fixed to a lot of monitors or tubes that she might not be able to move around quite as well. And also, any mom who's walking the halls needs to be accompanied by someone just to make sure that she doesn't fall. So the next thing is breathing techniques. So in early labor, this might be slow chest breathing. So they're breathing in slowly through their nose and out through the mouth. And breathing might be a little bit more difficult as she moves through active labor, and that's actually where the support person can come in and help them. Ultimately, you're trying to affect the parasympathetic nervous system. So basically, you're decreasing that pain response, and you're just decreasing the ability to feel pain overall. The benefits are that it decreases anxiety and the duration of labor, and there's no risks in oxygenation. We want to make sure that the baby is well oxygenated throughout. So one of the techniques that's been taught for the past couple decades is Lamaze breathing, which is basically an exercise on not only pacing breathing, but also on mindfulness. So as the mother breathes in through her nose and breathes out, she's focusing on relaxing the tension throughout her entire body from her head to her toes and letting her breath control the movement of the baby and kind of turning inwards and being guided by her contractions. So next is manual techniques. So touch includes hand-holding, stroking, caressing, embracing, and the primary effort with this is just to help the mom feel supported and feel that she can do this, that she can continue with labor. It's shown to reduce vocal and also physical indicators of pain, and it's really helpful to have a support person there to help out with touch and also massage. So with massage, one of the theories is actually a gate theory. So the idea that the pressure from the massage reaches the brain faster than the pain message does, effectively closing the gate in the brain to the pain. The other possibility is that it's actually stimulating the vagus nerve, which lowers cortisol levels. And they measure the effects of it by measuring the decrease in the maternal blood pressure during labor, and also they've noticed an improved postpartum outcome for both mother and baby. The next non-pharmacological method is hydrotherapy, and so this might look like a variety of different things. So they might have a shower in a hospital, or they might have like a rented sort of kiddie pool looking device that the mother can soak in an outpatient. And actually some hospitals have actual baths, so this is an outpatient birthing center unit. And And the goal with this is having the mother sit, kneel, or recline in the tub where the water covers her entire abdomen or her trunk. And the benefits is generally moms use less pain relief methods, and also because of the moisture, they have an easier time stretching as the baby comes out, so there's less need for the perineal repair. And also there's shorter duration for first-time moms. As far as the risks, it kind of goes back and forth. There's a lot of debate on whether there's a greater infection risk with a water birth or with a hydrotherapy approach to labor. Some of the studies pointed out that prolonged membrane rupture with hydrotherapy was more risky than a normal birth without the extended membrane rupture. However, evidence has gone back and forth. Like, there is a couple different studies with upwards of 600 women who didn't have any case of neonatal infection regardless of what their membrane status was. Alright, so as I talked a little bit before, like, emotional support is really important just because that person is there to give words of encouragement. They're there to help the mother focus. They're there to provide massage. They're also there for safety reasons. They're going to be fully attentive to the mother, and if they're educated on what they should expect and what concerns look like, then they can also talk to the nurse or talk to the doctor about, like, hey, this happened and I'm concerned about it. Overall, having emotional support there lends itself to better maternal and fetal outcomes. So it's important to also be concerned about cultural practices, because how much of her birth does the woman want her emotional support person to see? And if something emergent should happen, what do they want? Do they want the person to go with the baby? Do they want them to stay with mom? And another study, and actually a couple, was shown to support this, that 2 support people have been shown to be ideal for both the mom and the staff, because not only do we want adequate support for mom, but we also don't want to interfere with any medical processes going on. So if we have an entire group of people and we don't have the space for them, like, it could potentially compromise the mother's safety. So talking here between the nurses, and the next one is the doulas. The nurses are primarily a little bit more focused on clinical tasks because they have that documentation. They have an intermittent presence. They might have more than one patient. They do want to focus on the physical safety of the mother, medication administration, as well as assessment. But also keep in mind that while you're assessing, you can assess the emotional needs. You can provide for the emotional needs of the mom. I really liked this quote by Penny Simpkin. The common myth is that if she isn't hurting, she doesn't have any emotional needs. And ultimately, the nurse can help in normalization of the birthing process while she is working through her assessments and through her interventions. Or his. So I liked this infographic between the doulas and the midwives. So ultimately, doulas don't have any sort of clinical responsibilities. They're mostly a supportive role, so they're just continuous physical, emotional, and informational labor support. However, it really takes the load off of the nurse and off of the midwife so that they can really focus on the birth process itself. And the doula is there to explain through everything and make sure that the woman feels safe and confident during her birth. The doula also acts as an advocate for the woman to make sure that all of her birth measures are followed, and if some of her birth wishes aren't followed, that the woman understands why or why not. Alright, so pharmacological interventions. So the first one I'm going to go through is opioids, and I set this up in the SOC format, so side effects, organs, cautions, contraindications, and must-know drugs. Opioids typically have similar monitoring. We want to know what their previous response to pain relief was, because if they were responsive to 0.5 milligrams of an opioid, we don't want to give them 2 milligrams because we're risking respiratory depression and just worsening those side effects that they might experience. The other things we want to be monitoring for is pain assessment before and after administration, and then vitals, so blood pressure, pulse, and respirations, and also level of sedation. So the things that you need to know about Stadol is it can actually cause urinary retention, especially if the woman already has IV fluids infusing and has received regional anesthesia. and it shouldn't be given with a monoamine oxidase inhibitor, which is a drug for depression, or in women that have chronic hypertension. So with Nuvain, you still have the same monitoring. You can still give it IM and IV, but this one actually carries another risk that it may exacerbate underlying seizure disorders, so it's important that the doctor knows about that. However, in contrast to Stadol, it actually is less associated with nausea and vomiting. So with Demerol, it also shouldn't be given with seizure disorders or with monoamine oxidase inhibitors. And you're still monitoring for the same things, the previous response to analgesics, pain assessment before and after administration, as well as blood pressure, pulse, respirations, and level of sedation. And with fentanyl, fentanyl is actually given in micrograms. It actually acts quicker, but it also clears the system quicker than other opiates. And so it causes a little less of the neonatal neurobehavioral depression, so that's the sleepiness and the respiratory depression that the baby might experience after they're born, if they're given opiates too late in the pregnancy. So epidural is actually a combination of an anesthesia and an opioid, and the patient might be able to control it via a patient-controlled pump. It's important to know that before insertion that we're trying to protect the woman from hypotension, so that she needs to have a large bore 18 gauge IV, as well as be given a bolus of 1 liter of fluid. And we again want to be monitoring blood pressure, pulse, and temperature, because this one actually has a risk of a low-grade fever. And we want to have continuous fetal monitoring, because our goal ultimately is pain relief, but it might have the effect of a little bit decreased motor or sensation, depending how the dose is monitored. If the woman does experience hypotension, it's important to increase the flow rate and then also get ephedrine on board, so 5 to 10 milligrams IV, as well as notify the OB physician. The last one is nitrous oxide. So this one is actually given through inhalation, and it's primarily metabolized by the lungs. It has a really short duration of 2.5 minutes. The reason why it's so safe is because it's patient controlled. So the patient can breathe in, and if the patient gets a little dizzy or anything else, they can bring it away from their face. Actually, just going back to nitrous oxide, one of the contraindications is hypovolemia, and that's just because of lowered blood volume, that it can increase the effects of the hypotension and be potentially unsafe. And that helps us climb our mountain. And of course, it's important to have a map. So this is a handout that is given to mothers and families, of course. And basically what it outlines is, what are their hopes for the childbirth experience? Where did they get their information? What interventions do they or do they not want? Who are the key players? Like, who is their practitioner? How do they feel about breastfeeding? It's kind of an assessment tool overall to help the mother have a safe and satisfying birth, and also let the staff understand what her wishes are prior to the labor event. And of course, this is getting us to our goal of a safe, satisfying, and healthy birth of their newest family member.